Welcome to our session on discharge planning and follow-up for NICU infants. Discharge planning is one of the most important things we do. It's not just about getting a baby out of the unit. It's about setting that infant and family up for success. Let's get started. Here's what we'll cover today. We'll start with how to assess discharge readiness, then move into immunization and screening protocols, which show up frequently on the exam. We'll also talk about coordinating follow-up care, parent education for home care, special considerations for high-risk infants, and community resources. This comprehensive approach reflects what's actually tested on the exam, with extra emphasis on the topics that appear most often. The first thing to understand is that discharge planning isn't something we start the day before a baby goes home. It begins the moment that baby is admitted to the NICU. This is a family-centered, multidisciplinary process that involves not just nurses and neonatologists, but also social workers, respiratory therapists, nutritionists, and more. The goal is to ensure a safe transition from the controlled NICU environment to the home. And here's something important. Discharge planning should involve regular care conferences throughout the entire hospitalization. This ongoing nature of discharge planning is an important concept that might appear on your exam. Let's talk about specific infant criteria for discharge readiness. There are several key physiologic competencies a baby must demonstrate. First, thermal regulation. The infant must maintain temperature in an open crib, typically for at least 24 hours. Second, feeding. The baby needs to show a steady weight gain pattern. For most preterm infants, this means consistent weight gain of 15 to 30 grams per day. Third, respiratory stability. Cardiopulmonary stability should be demonstrated for a sufficient time frame, usually 5 to 7 days, without significant events. Fourth, all routine screening tests and immunizations must be completed before discharge. This includes hearing screening, metabolic screening, and appropriate immunizations. Finally, if there are any specialized equipment or medication needs, the infant should be stable on these therapies. Now, for parent and caregiver readiness, equally important, but sometimes overlooked. First, we need at least 2 primary caregivers identified. Second, caregivers need to demonstrate emotional and psychosocial stability and confidence with infant care. This isn't about being perfect, but about being ready. Third, they must show competency in both basic care and any specialized care the infant requires. Fourth, the home environment needs to be prepared, with essentials like a crib, diapers, formula if needed, and any medical equipment. Many hospitals have programs to help provide resources to families in need. Finally, support systems and resources should be in place before discharge. This includes a scheduled appointment with a pediatrician. Preterm infants follow the same immunization schedule as term infants based on chronological age, not corrected age. This is a key point that's frequently tested. For infants born to HBs-AG positive mothers, the protocol is very specific. Administer both HBIG and the hepatitis B vaccine within 12 hours of birth. For RSV prophylaxis with palivizumab, know the current AAP guidelines for which infants qualify. Generally, this includes infants born before 29 weeks gestation, infants with chronic lung disease, and certain infants with congenital heart disease. Yearly influenza vaccination is recommended for both the infant, after 6 months of age, and all caregivers. These specific protocols and timings regularly appear on the exam. For varicella exposure management, know that Varizig is indicated when maternal rash develops within 5 days before to 2 days after delivery. If the maternal rash occurs more than 5 days before delivery, infection is unlikely because protective maternal antibodies have had time to cross the placenta. Regarding live vaccines, there are special considerations in the NICU setting. Live vaccines are generally contraindicated in significantly immunocompromised infants. The specific immunization protocols, especially for hepatitis B and varicella exposure, are frequently tested on the exam. Critical congenital heart defects affect approximately 2 to 3 per 1,000 newborns and can be life-threatening if not detected early. evidence now strongly supports pulse oximetry screening as an effective, non-invasive method for early detection that significantly reduces infant mortality and morbidity. The American Academy of Pediatrics and American Heart Association have established a standardized screening protocol for all infants. This screening occurs between 24 and 48 hours of age, either in the well infant nursery or shortly before discharge. The protocol involves measuring oxygen saturation using pulse oximetry on both the right hand and one foot. The right hand reflects preductal circulation, while the foot represents postductal circulation. A screen is considered positive under 3 circumstances. First, if any oxygen saturation reading falls below 90%. Second, if saturation remains below 95% in both extremities across 3 separate measurements taken 1 hour apart. Or third, if there's consistently more than a 3% difference between the hand and foot measurements across 3 readings. Infants who fail the initial screen receive repeat testing, and those who continue to fail are referred for immediate cardiology evaluation. This systematic approach has proven highly effective in identifying critical heart defects before clinical symptoms develop. Hearing screening is another high-yield topic. Universal screening should be performed prior to discharge. Know the difference between the 2 testing methods: ABR, auditory brainstem response, and EOAE, evoked autoacoustic emissions. ABR evaluates neural activity in response to sound, while EOAE measures sound produced by the outer hair cells of a normal cochlea. ABR is recommended for NICU screening because it can detect auditory neuropathy, which EOAE cannot. If an infant fails the initial screening, they should be re-screened before 1 month of age. If they fail the second screening, a full auditory evaluation is needed by 3 months of age. Family follow-up support is critical because many babies who fail initial screening are lost to follow-up. These protocols and timelines frequently appear on the exam. Car seat testing is a commonly tested topic. It's required for all preterm infants, less than 37 weeks gestation, prior to discharge. It's especially critical for infants born at 34 weeks gestational age, as they may appear otherwise stable but still have positional airway issues. Car seat testing is also needed for infants with certain conditions like trisomy 21 or other conditions that might affect airway control. During testing, we monitor for apnea, bradycardia, and desaturation events while the infant is positioned in their car seat. The test typically lasts 90 to 120 minutes. This must be completed successfully before discharge, and the exam often tests your knowledge of which infants require this testing. Follow-up timing is another high-yield area. For late preterm infants, 34 to 36 weeks, the first follow-up visit should occur within 24 to 48 hours of discharge due to their higher risk for feeding difficulties, jaundice, and temperature instability. High-risk infants need a comprehensive follow-up schedule based on their specific needs. For growth monitoring, weight should be corrected for prematurity until 24 months of age, which means comparing the infant's growth to what would be expected at their corrected age. Specialized follow-up might include developmental assessments, specialty care for specific conditions, and early intervention services. Let's break down the follow-up schedule by age. At 1 to 3 months corrected age, we focus on adaptation to home, verifying accuracy of home medications, and addressing parental concerns. By 4 to 6 months, we're looking for adequate catch-up growth and identifying any severe neurologic abnormalities requiring intervention. At 8 to 12 months, we're focused on identifying suspected or confirmed cerebral palsy or other neurologic issues. The 18 to 24-month visit is crucial for administering the Bayley Scales of Infant Development, BSID-3, to assess cognitive functioning. By 3 to 5 years, we're evaluating for subtle neurologic, visual-motor, and behavioral difficulties that might affect school performance. Parent education is fundamental to successful discharge. For basic care, we cover thermal regulation, teaching parents how to take temperatures and dress their infant appropriately. Feeding education includes proper techniques, whether breast, bottle, or specialized methods, and how to prepare formula if needed. Bathing and hygiene instruction covers cord care, skin care, and diapering. Sleep positioning education emphasizes placing infants on their backs to reduce SIDS risk. We also teach parents to recognize signs and symptoms of illness and when to call their healthcare provider versus seeking emergency care. This distinction, knowing when something can wait versus when it's urgent, is crucial for parents and might be tested on the exam. SIDS prevention education is frequently tested. The back-to-sleep position, not prone, is the single most effective intervention to reduce SIDS risk. Parents should provide a firm sleep surface with no soft objects or loose bedding. Room sharing without bed sharing is recommended. The infant should sleep in the parent's room, but on a separate surface. Pacifier use at sleep time may be protective, though we typically advise waiting until breastfeeding is well established if that's the feeding method. Parents should avoid overheating the infant during sleep. The triple risk theory is the current understanding of SIDS pathophysiology, involving a vulnerable infant, a critical developmental period, and external stressors. For infants requiring specialized care, additional education is needed. Medication administration teaching should emphasize using milliliters only for dosing, never household spoons to prevent dosing errors. Parents should begin administering medications prior to discharge under supervision to gain confidence and demonstrate competence. For equipment management, parents need hands-on training with any oxygen, monitors, or feeding tubes their infant requires. Emergency care plans, including CPR training, are essential for all caregivers. Parents also need a clear follow-up appointment schedule and understanding of the importance of keeping these appointments. Understanding the management of minor findings is a testable area. For an intergluteal dimple with a normal ultrasound, simple observation is appropriate. Physiologic vaginal bleeding in female newborns just needs reassurance. It's a normal finding related to maternal hormone withdrawal. If you see blood in an infant's stool with ecchymosis, consider vitamin K administration, 1 mg IM, if it wasn't previously given. For torticollis, remember its association with developmental hip dysplasia and ensure appropriate screening. You may see questions about routine care and what to do when a parent refuses basic care and what assessment finds are normal versus concerning. Some infants go home with special equipment needs. For those with a gastrostomy tube, parents need education on formula selection and preparation, as well as tube care and troubleshooting. For respiratory support, training on home oxygen and apnea monitors is essential. Infants needing specialized airway support should have a waking polysomnogram before discharge to ensure adequate home settings. Equipment vendor coordination and training should be completed well before discharge. Parents also need emergency backup plans for equipment failures, including who to call and what to do while waiting for help. The exam may test your knowledge of discharge planning for infants with specialized equipment. Understanding correction for prematurity is important for the exam. For growth parameters, we use corrected age from due date, rather than chronological age from birth, until 24 months. For developmental milestones, correction is typically used until 2 to 3 years of age. For extremely low gestational age newborns, LGANs, born at 23 to 25 weeks, some literature suggests continuing correction until 5 years of age. Whatever standard is chosen, a consistent approach is needed among all team members to avoid confusing parents with different expectations. Early intervention services have been shown to improve neurobehavioral development, with better cognitive outcomes and parent-child interactions. The eligibility criteria and referral process vary by state, but generally include infants with developmental delays or conditions likely to lead to delays. Services might include occupational therapy, physical therapy, speech therapy, and developmental therapy. The Individuals with Disabilities Education Act requires each state to provide services up to 3 years of age for eligible children. Coordination between EI, primary care, and specialists is essential for optimal outcomes. Beyond medical follow-up, families often need additional community resources. Home health services can provide nursing visits or specialized care. Parent support groups offer valuable emotional support and practical advice from those who've had similar experiences. Many families need financial assistance programs for medical expenses, equipment, or medications. Transportation assistance may be necessary for families without reliable vehicles to attend follow-up appointments. Equipment and supply resources can help with ongoing needs. State-specific early intervention programs provide developmental services. Family counseling services can support adjustment to life with a medically complex child. Knowledge of these resources may be tested on the exam. A comprehensive discharge summary is essential for continuity of care. It should include both resolved and ongoing problems, so the primary care provider knows the infant's medical history. All completed screening results and future screening needs should be documented. Current medications with exact dosages need to be listed. Primary care and subspecialty follow-up appointments should be clearly scheduled with dates if possible. Growth parameters and the nutritional plan should be detailed. Emergency contacts and care plans should be included for quick reference. This comprehensive summary should be given to primary care providers, subspecialists, and parents. Understanding long-term outcomes is important for comprehensive care. Neurodevelopmental impairment risks for NICU graduates include cognitive delays, motor issues like cerebral palsy, sensory impairments, and behavioral challenges. School-age outcomes often involve academic achievement challenges, with many children needing individualized education plans. Behavioral challenges commonly include ADHD and internalizing problems like anxiety or depression. Executive functioning concerns can affect planning, organization, and self-regulation. Educational achievement and vocational outcomes may be impacted in young adulthood. While less frequently tested directly, understanding these long-term outcomes provides context for the importance of proper discharge planning and follow-up. Let's review the key concepts to remember for the exam. Immunization schedules follow chronological age, not corrected age. This is frequently tested. CAR-C testing is required for all preterm infants, especially those born at 34 weeks. Hearing screening protocols require follow-up by 1 month for failed initial screens and full evaluation by 3 months for failed second screens. Growth parameters use corrected age until 24 months. ROP screening is required for all infants less than 1,500 grams or less than 30 weeks gestation. SIDS prevention education must emphasize back sleeping position as the most important intervention. To summarize, discharge planning is a process that begins at admission, not the day before discharge. It requires a multidisciplinary, family-centered approach to be successful. Both the infant and caregivers must meet specific readiness criteria before discharge can occur. Follow-up coordination is critical to long-term outcomes, with clear scheduling and communication between the NICU and follow-up providers. Parent education and community resource connection promote a successful transition from hospital to home. Remember that a NICU stay is just a small part of these infants' lives. Our discharge planning and follow-up coordination set the stage for their long-term development and success. A neonate born at 28 weeks gestation is being prepared for discharge from the NICU. The mother asks when her baby should receive the first set of routine immunizations. The nurse's response should be based on the knowledge that immunizations should be administered according to chronological age, corrected age, weight criteria. The correct choice is chronological age. This question is testing your knowledge of immunization protocols for preterm infants. Chronological age is correct because preterm infants should receive immunizations based on their actual age from birth, not their corrected gestational age. The AAP recommends that all preterm infants receive routine immunizations according to chronological age, regardless of birth weight or gestational age at birth. Corrected age is incorrect because using corrected age would delay immunizations unnecessarily and leave the infant vulnerable to preventable diseases. Weight criteria is incorrect because while clinical stability is considered, specific weight thresholds are not the determining factor for timing of routine immunizations in preterm infants. An infant is born to a mother who tests positive for hepatitis B surface antigen over HBsAg. What immunoprophylaxis should be administered to this neonate? Hepatitis B immune globulin only. Hepatitis B immune globulin and vaccine within 12 hours of birth. Hepatitis B vaccine only within 24 hours of birth. The correct choice is hepatitis B immune globulin and vaccine within 12 hours of birth. This question is testing your knowledge of specific prophylaxis protocols for infants born to HBs-AG positive mothers, which is a high priority topic on the exam. Hepatitis B immune globulin and vaccine within 12 hours of birth is correct because this combination provides both passive immunity from the immune globulin and stimulates active immunity from the vaccine. This dual approach provides immediate protection and long-term immunity development. Hepatitis B immune globulin only is incorrect because while it provides immediate passive protection, it doesn't stimulate the infant's immune system to develop long-term immunity. Hepatitis B vaccine only within 24 hours of birth is incorrect because infants exposed to hepatitis B need immediate passive immunity from immune globulin along with the vaccine, and the timing requirement is more strict, within 12 hours, not 24. A neonate who failed the initial hearing screen is rescreened and fails again. By what age should this infant have a full auditory diagnostic evaluation? 2 months of age, 3 months of age, 6 months of age. The correct choice is 3 months of age. This question is testing your knowledge of hearing screening protocols and follow-up timelines, which appears frequently on the certification exam. 3 months of age is correct because according to the Joint Committee on Infant Hearing 136 recommendation, infants who do not pass the second hearing screen should have a comprehensive evaluation by an audiologist no later than 3 months of age for confirmation of hearing status. 2 months of age is incorrect because while earlier evaluation is beneficial, the standard recommendation is by 3 months. 6 months of age is incorrect because waiting until 6 months delays potential interventions unnecessarily, and the standard recommendation is that appropriate intervention should begin by 6 months of age for confirmed hearing loss. Neonate born at 34 weeks gestation is being prepared for discharge. What testing should be completed prior to discharge? Brainstem auditory evoked response only, CARC testing, MRI of the brain. The correct choice is CARC testing. This question is testing your knowledge of discharge preparation for preterm infants, specifically CARC testing requirements, which is a significant topic on the exam. CARC testing is correct because all infants born at less than 37 weeks gestation require CARC testing prior to discharge to assess for potential cardiorespiratory compromise when positioned in a semi-reclined position. This is especially important for infants born at 34 weeks due to potential immature respiratory control. Brainstem auditory evoked response only is incorrect because while hearing screening is important for all infants, it doesn't specifically evaluate the cardiorespiratory tolerance of CARC positioning that preterm infants need. MRI of the brain is incorrect because routine MRI scanning is not required for all preterm infants prior to discharge, unless there are specific neurological concerns. When discussing SIDS prevention with parents, which intervention should be emphasized as most important? Avoiding bed sharing, placing the infant on their back to sleep, using a pacifier during sleep. The correct choice is placing the infant on their back to sleep. This question is testing your knowledge of SIDS prevention education, particularly the most critical intervention, which is a frequently tested topic. Placing the infant on their back to sleep is correct because the back sleeping position is considered the single most effective intervention for reducing SIDS risk. This recommendation has resulted in significant decreases in SIDS rates since the back to sleep campaign was introduced. Avoiding bed sharing is incorrect because while it's recommended to room share without bed sharing, the back sleeping position has been shown to have the most significant impact on SIDS reduction. Using a pacifier during sleep is incorrect because while pacifier use at sleep time may be protective against SIDS, it's not considered the most important intervention compared to back sleeping position.